And good morning, everyone, and welcome to PerfWeb 86, Day 2. We've got a great program set up for us today. The first part of the morning is going to be just me, and I'm going to be talking about recirculation in your ECMO circuit as a vital sign indicator, and something that I think we really need to pay a lot of attention to and be very cognizant of. But before I get started, as you all well know, I have to do the housekeeping notes that I'm obligated to. As far as any kind of disclosures are concerned, with the first part of this today, I have no financial interest in Transcranial as a company. We are going to be talking about their device, and it is the only device available on the market to measure recirculation in your V-V ECMO circuit or oxygenator blood volume, which would be indicative of course, thrombus and inadequate heparinization or anticoagulation, whichever medication you may be using. To contact us, you go to contact@perfusioneducation.com. You see it down there. Our call-in number is always up and available. You see it there. For those of you that may be driving that want to call and be live on the show to say anything, ask any questions, whatever the case is, 832-239-5358. That's 832-239-5358. And it'll be up there the whole time. If you want to jot it down or call us later, that'd be great. The scroll bar for all of this information is always at the bottom of the screen, no matter what we have going on. And then I'd like to talk about our MediWeb app. Our MediWeb app, of course, is, I think, one of the best apps going. For example, I can't show you on the screen. We didn't set that up for this morning, but I can, for example, and I think this is really important, go to the what is the perfusion section. So if you're a perfusionist, you would click on the perfusion section. You would click perfusion quick calcs. You have a female patient who calculates the volume automatically at 65 mLs per kilo. She's 65 years old. She has a pre-op hematocrit of 32. Her height is 160 centimeters. Her weight is, I'll say, 67 kilograms. The pump prime volume is 1,000 cc's. Anesthesia has given the patient 1,500, and the patient has put out 500 cc's of urine so far, and your heparin dose calculation is based on 300 units per kilogram. And I click on calculate, and it gives me the BSA, BMI, estimated blood volume, red cell volume, heparin dose, estimated on-pump hematocrit, protamine dose, and then your calculated flows from 1.6 to 3.0. All right here on your phone, making your pre-pump calculations, your setup calculations for your case very, very, very easy. You can calculate O2 transfer rate. You can calculate oxygen delivery, DO2. You can look at the amount of oxygen left in your E-cylinder if you were using a portable oxygen for, let's say, ECMO. You have an ECMO section which has SaO2 or your arterial oxygen content. It has your O2 AVO2 difference. It has also DO2I, colon-oncotic pressure, O2 transfer rate, ECMO selection algorithm, Murray score for acute lung injury, ABG interpreter, PF ratio, just a tremendous amount of stuff right here on your phone. You can go to the Google Play Store or you can go to the iTunes Store, look up MediWeb, critical care application for perfusion. There's also a standalone IV rate and dose calculator by us. You get free updates for life. It's $2.99 for the big app, 99 cents for the small app. There's my plug for the day, and would love for you to be a customer and to buy it and use it and let us know. Leave us a review. Be appreciated. You want to listen to us on podcasts, go to your favorite podcast streaming software, whether it be Spotify or Podbean or whatever service you use, and you can always listen to all of these programs live or as they were recorded. You can leave live comments if you're on YouTube, and if you do, it pops up and I automatically see it, and they're always appreciated. So please leave some comments. I would greatly appreciate that. And let me think. I can't think of anything else at the moment, other than I do want to talk about the second half of the program. The first half is what it is, but the second half of this program is going to be exceptional. We're going to have some, and I'll introduce them when we do the program, but they are from NovaSignal. And this is the world's first autonomous transcranial Doppler, we'll call it a robot, that uses AI in order to fix on a signal through the temporal window and I think maybe even orbital window, and be able to look at cerebral blood flow during a whole variety of procedures, including cardiac surgery. And I think whether it be on pump or off pump, it has tremendous utility in that. And I think we really need to learn about this and really appreciate its value. But of course, it's also used for a lot of other things, which we're going to learn about today in the critical care unit, ECMO patients, cath lab, neuro unit, vascular surgery, carotid surgery. So tremendous application for this technology. And it is now designed so that you don't have to use a sonographer who is skilled to aim this and keep it in one place, especially if it gets jostled around. So I think this is going to be very exciting technology. So that's our second half for today, which will likely be the most popular part of the PerfWeb 86 series yesterday and today. With that said, I'm just going to jump right in. Yes, sir. We lost connection. Share again. Oh, you lost connection with the... Oh, I'm sorry. So we're not going to jump right in. We're going to wait. I'm going to share the slides first, and then we're going to jump right in. Okay. Okay, now we're going to jump right in. We're going to go to recirculation, a vital sign indicator for V-V ECMO patients. And again, I'm Joe Basha, perfusionist. No disclosures, we discussed that. I do have to say that Transonic did generously allow me to share many of their slides. So that is fair to say that. Patients go on V-V ECMO for severe respiratory failure, not responding to other conventional modalities. Cardiac function is generally still intact, and hypoxia must be addressed. And I don't mean to interrupt you, David, but is there that screen, the one that's being aired, it keeps flickering really fast? Like, is there something I need to do? Is it still airing, like, or is it doing this online? They don't see it online. Okay. Connection in here. Okay, thank you. Sorry, folks. So recirculation is a very well-known, understood complication of V-V ECMO. We want as much blood flow to go from the reinfusion cannula, whether it be a single cannula strategy or a dual two catheter strategy, towards the right ventricle so that we maximize its effectiveness. Indications that recirculation is occurring have historically been left up to the specialist at the bedside to determine. And excuse me one second, could you possibly just call him? It's just incredibly distracting for me. No, I would call Magic and ask him to come help. V-V ECMO cannulation configurations that are common with V-V are what you see here, where you have your access coming from the femoral vein being put way up high, And in this case, it's a little lower. I take that back. And your return in the contralateral femoral vein that is higher. So because flow is this direction, you want your reinfusion to be up higher than what your access is. In this configuration, you're accessing from the inferior vena cava, and then you're returning it back into the right IJ, going back into the right atrium. And then in this example that you have here, you see the double lumen catheter, single catheter, double lumen, where you're accessing from the inferior vena cava, superior vena cava, and you're returning to the mid portion of the right atrium. Typically angled towards the tricuspid valve, but these are kind of tricky to make that happen. In this particular circumstance, what you see is your access here, and you see your IJ catheter here, and you notice that, of course, there's different outlet ports. Some of the blood is sort of swirling around. Some of it is being dragged with the normal blood flow into the right ventricle, but some of it, you see the purple, is getting mixed up and brought down here. And this is what basically diagrammatically what recirculation would look like. So here you see radiographically, I mean, there's very little distance between the tip of your IVC access catheter and the return of your SVC cannula, your return cannula. So when these distances are this short and you have essentially flow going this way, it's really easy, and I can draw that for this flow because it's jetting and this is vortexing to just get pulled this direction. And you're going to lose a lot of effectiveness of your ECMO flow when these cannulas are that close to one another. In the bifemoral approach, what I showed you earlier, you see that this is your access here, here is your return here, but because even though you do have native blood flow is going this direction, so you have washout, which is going to help you, the pull from here creating the vortex is going to suck some of the volume just directly back, counter to the flow into the cannula. Though I believe, and my experience in these different techniques tells me that if you can have this cannula here low enough, this access low enough, just about, at the hepatic level, and here's the hepatic vein right here, and this return in the right atrium, the amount of recirculation is a lot less with this technique versus this technique, especially when they are this close to one another, which is very short. In this example here, you see they're both very, very low, and sometimes you will just not get good drainage when they're like that. So I don't necessarily recommend that technique. Here's the double lumen, and you want it to be perfect, but of course, the higher the lower, I will say, the patient's cardiac output, the higher your recirculation is going to be here. And actually, when you have zero recirculation in this type of model, you're almost always going to be able to predict that you have high cardiac outputs and are very hyperdynamic hearts in that particular circumstance. But these have become very, very, very popular. Here we see radiographically what it looks like with the cannula overlaid over the heart shadow and how it is intended to work. One of the things you can use as an interesting marker is when this cannula becomes narrower, right in this area, is where the outlet is. And that's really easy to see on the chest X-ray. And of course, there's your cannula in place. So clues about recirculation. And I'm sorry, please forgive me for 1 second. Hey, Magic,
Yes.
are you still working on it, dude? It's just,
Yeah,
it's
right
kind of making me crazy.
I
Can you just turn them off? Because
if it's gonna do something, I can try, but I'm not sure we're gonna lose the speed.
okay, I mean, at this point in time, I just can't do this. It's too distracting. I understand. Well, yeah, but it's really, you don't have to turn that one off. I just turn this one off. I'm good. It's just, it's real hard for me because it's blinking and it's driving me crazy. So I apologize for that. Technical difficulties. So what you're looking for is recirculation clues is the patient's arterial saturation is going to start falling while your pre-oxygenation saturation is going to go up. So this is going to be, so let's just hypothetically say you're satting 98. Now all of a sudden you're satting 93. Well, that could be for extraction reasons. It could be that people are using they may be coming off of paralytics, moving. Temperature could be going up. There's a whole variety of reasons. But when that happens in concurrence with what was, let's say, 65% at one time, and now it's reading 78% or 80%, you see a relationship happening there. And so generally speaking, if you have an extraction problem, you're not going to see this drop and this go up. So that is sort of the classic way that we diagnose recirculation in our ECMO circuits. So the change in effective pump flow and recirculation compared with set pump flow in V-V ECMO is thus, because what this graph is going to show us is that our instinct is to turn the ECMO flow up. But if you look at this graph, here you have your effective ECMO, your flow right here, and your recirculation. And here you see your effective ECMO flow. So as you go up on flow, your effective ECMO flow goes down because your recirculation reaches a certain point. So you cannot just turn the flow up, because doing so can actually exacerbate an already problem of recirculation. So you'll make the recirculation worse, and we don't want to do that. But of course, it's important to be able to just measure it and really understand it very quickly. Let's just, in this particular setting, let's say that your saturations, in this case, your max RPMs with little increase in your SaO2, venous and arterial ECMO lines show similar coloring. Patient oxygenation saturations remain low. That would be the patient saturation from, I prefer, of course, the right radial, but any really radial at this point in time, because on VV it doesn't really matter like it does on VA. But as a habit, I would always try to shoot for the right radial. Mixed venous oxygenation monitoring reads high if you're using that. Patient requires similar amounts of inotropic support because you've got problems. Patient's NIRS monitors or readings are suboptimal, and arterial blood gas PO2 remain low. Ventilator settings remain elevated. You're not even right now able to rest the lungs. So how are we helping this patient? And really, in reality, we're not. We're hurting this patient, which is not what we all signed up to do, because we have now essentially inserted a very invasive technology, therapy, equipment, disposables, blood contact area, and it's doing the patient no good, but it's doing harm because all of those things increased risk, are very pro-inflammatory, anticoagulation, higher risk of stroke. All of these kinds of things play a role. So it's very important that if we're going to use a therapy, that we maximize that therapy's effectiveness for obvious reasons. So this is where this device, the transonic ELSA meter, comes into play. And again, I just remind everyone, I have no financial interest in this company, but I think that this is an incredibly useful device that I use as much as I possibly can. And it has multiple uses. So it's not just this is for one thing and one thing only. It has multiple things that it can do. We're going to discuss some of those. It has 2 flow measurements that use transit time indicator dilution technology. A saline bolus is given through the ECMO circuit to determine recirculation percentage. Now, with that said, every device has limitations. If you're using the CardioHelp, it has limitations, and we can discuss that maybe later, but your circuit does have to be designed a certain way, and I'm going to show you that as we move forward with these slides. Flow sensors acknowledge the difference in velocity to quantify the recirculation measurement. So basically what you do is you give a bolus of saline into blood. The first pass measures the velocity change, and then, because there's a difference, of course, in viscosity, and as that saline is pulled back to the access line, if it is, then it sees that change in velocity as well and can compute what the percentage of that recirculation actually is. And it gives you the numbers, which you see here. This is a recirculation of 21%. You're actually flowing 1647, but your effective ECMO flow is only 1301. So you're 1.6 liters or 1.65 liters, but your effective flow is only 1.3 liters. Now, at 21%, I'd be hard-pressed to want to make a change unless I really had to. That's, anything under 15% and under is exceptional. 20% is good, and not perfect, but good. And so I'd be disinclined to want to change it. 21% is too close to 20 for me to make consider making a change. Now, you could have 41% recirculation, which means you're flowing 3.6 liters with an effective ECMO flow of only 2.1 liters. That can make an enormous difference. And basically what you see is the first pass through the line post-oxygenator, and here it is coming back to the access line. And then what you see here is it just going back through the system. But these are the ones that you want to be most focused on. This is showing a video of the recirculation measurement, but it's also simultaneously measuring oxygenator blood volume. So I'm going to let it run through, and then I'm going to talk about it. So let me run that video one more time if I can. I think I have to go this way. Okay, watch the syringe right here is going to give an injection. It is between the pump head and the oxygenator. You'll see the white line go through the oxygenator. This is where oxygenator blood volume will be measured. Then it goes through this sensor and it picks up the bolus, and that's going to be your red curve. Goes up into the patient, comes back down the access line through the flow probe, and that is what's going to measure. That's going to be your blue line and measuring your recirculation. So let's let it do it. There's the injection. There's the marker going up through the oxygenator. There it is going through the red flow probe. There's your red curve. Here it comes, coming back the access cannula into the flow probe. There's your blue curve. And this didn't calculate a number, but that looks like it's probably down around 15–20%. Okay, and here you see where it gave you the oxygenator blood volume. So even if you didn't do it as a baseline, you can look at this at a later time and say, hey, our oxygenated blood volume is trending down. That can be an indication that you're starting to lose surface area, and that's going to be due to thrombus. Recirculation, we talked about that already. Here we looked at this about the recirculation, and that we talked about this already. Let me talk about this real quick. This technology was introduced by Dr. Krivitsky, Nikolai Krivitsky, in 1995. He published his findings in a SIO. He has over 200 papers in the hemodialysis, ICU, and ECMO fields, and measurements are easy. 1 saline bolus and 1 minute of time is what it takes. I do adults only. I know there's a formula for children, for neonates, and for pediatrics, but we usually use 15 to 20 cc's of saline per injection for our purposes. And this kind of shows you what the velocity is of saline versus the velocity of blood due to the change in viscosity. Here's the publication that we discussed, and it talks about the various different aspects of it. I recommend it. I think it's a good article, and I think that it explains a lot of things about the technology you may find interesting. So what are some of the additional technological values of this? Well, currently there's no test for clotting, and none that are quantitative. You have the flashlight method. You have D-dimer, which you could sort of say, well, my D-dimer is going up, and I might have clot. Your fibrin degradation products, your fibrin split products, whatever you want to call. Transmembrane pressure, but I will tell you that your transmembrane pressure may not change significantly enough with a lot of your circuit occupied with clot. You'd be surprised at what percentage of your oxygenator you can lose before you start seeing a significant rise in your delta P, your transmembrane pressure. Diminished oxygenation, of course, or when post-oxygen saturations begin to decline, or you start seeing post-oxygenator CO2 starting to rise. This generally is late in the game, and the patient maybe is not now in crisis, but crisis is impending. This is what an oxygenator looks like, and actually it's this oxygenator. That's what this oxygenator actually looked like. Here is your oxygenator blood volume test. If you select it in the menu, I always run, if I'm V-V ECMO, I run both recirculation, oxygenator blood volume. Obviously, there's no recirculation in VA ECMO, so you only run oxygenator blood volume. But that green curve is what is the oxygenator blood volume. Then you see your red first pass, and then your blue, and you get both oxygenator blood volume and recirculation. You can see that you're at 88% of baseline, or if you did not do a baseline, you can look at your IFU, know what the oxygenator blood volume is supposed to be, and if this is where that is supposed to be, you can actually set this whenever you do your first one as your baseline. So even, notwithstanding this is not set, you know what your oxygenator blood volume should be, and then look at what it actually is, and you can make some very important clinical choices and decisions with that information. Obviously, cannula placement, I can't, say enough how important that is. And I also want to mention something, I'm not sure if it's in this talk. I want to mention that this technology is FDA approved, number one, And number two, this technology is recommended by ELSO, the Extracorporeal Life Support Organization. This technology is proven to improve outcomes. So I think there's a lot to be said. And we haven't even discussed some of the other things that it can do, which I find very useful. You can optimize your RPMs in ECMO flow if you are not going to change cannula position in any way, shape, or form. You could be reducing, of course, hemolysis. You could, which of course is going to lead to increased inflammation, poorer effects of coagulation, and high links to acute renal failure, certainly acute kidney injury when you have high hemolysis. So you can optimize your RPMs and know when it's time you've got to correct the position of your cannula. And what's nice is you correct the position of the cannula where you think it needs to be. You can shoot a recirculation before the cannulator, physician, surgeon, whoever's putting it in, secures it in that place. You can verify, validate it very easily. This is sort of redundant, kind of says the same thing that I've already said. Hypo or hypervolemic, as I said, if you have right heart failure, you're going to see high recirculation even with optimal cannula placement. If you have a very hyperdynamic patient, then you are going to have very low recirculation, and it's usually going to say 0. Even if the cannula is not in perfect position. And the reason for that is that the patient's native circulation is so fast, 10 liters, 12 liters, you're flowing 3.5 or 4, you're nowhere, the blood's just flowing right by. There's no way for recirculation. Whereas with right heart failure, especially in V-V ECMO and low cardiac output states, that blood is, you're flowing 4 liters, the patient's own cardiac output is 3 liters, you're a liter over the flow, there's going to be significant recirculation, even if the cannula was in perfect position. So you see how this has a lot of use and can give you a lot of information with a very simple 1-minute test. And the cost is nominal, I will tell you that. The cost per test is 0. The cost of buying the machine is about $20,000, maybe it's $25,000, I'm really not sure exactly. But I think the overall cost compared to what we spend to do an ECMO patient is trivial, and it can be used on multiple ECMO patients, so you only really need one in the unit, and you can clean it from one patient's room, take it to another patient's room, and use it. You might need 2 if you have a lot of exotic hybrid cannulations because you don't want to move it once you have it on, and I'll explain to you why, because if you're monitoring multiple lines. We talked about the RV failure. That's the end of that lecture, but I'm going to do something here which wasn't on this. And let's just say you have, I gotta find a different slide. Give me just a second and I'll do that. You can take my slides down in case you had them up. Thanks. Let me see. I know it's in here somewhere. They're in here. I could get somebody to say something. Oh, are we going to fix that thing or not? That blinking. So I'm trying to finish early so that you can get it fixed because I really want it to be working for when we got these other lines up. Okay, you can bring my slides up. Thanks. So if you are doing this, and let me make sure, there we go. So if you are doing, I'm going to pick on VAV. Here we go. This one, D. Okay. And we're just doing V ECMO, where this line, I'm going to just mark it out. It doesn't exist. We're draining from here, pumping into here, going back to here. Well, to do this, I need one flow probe, right? Whereas when I go in and let me see. Man, I'll tell you what, this is, I'm just messing this whole thing up. Slideshow from current, there we go. Then I can do this and clear the pen markings, okay? Now I can't. I drew on the slide the wrong way. So, so now if I add this line to go VAV, I need two flow probes. I need one here, and I need one now on this line. But I'd also like to know the total. So I could put one here. So what the transonic device enables you to do is this would be hooked up to your regular ECMO. And here, I can just use this one. So let's just forget this one, and let's go down here to E. Here we have the access, we have the return, and I have the return split going here. Well, I want to know the total. So here's the ECMO flow probe. I want to know the flow going to the leg. Here's one transonic flow probe, but I want to know the flow going to the right IJ, and I can use that flow probe. So I can have all three probes on the monitor for me. Total is 4, and there's, let's say, 2 and 2. And if I want to adjust that, I can just change my clamps, and I can see in real time what that flow is. And I think that is such a critically important feature to have. Now, with all of that said, I usually do a test and ask anybody what they can tell me about this, but in the deference of time, I'm not going to do that because we are having some technical difficulties. They're minor, but we have, that, like I said, the best session of the day coming up with NovaSignal. We're going to have Mike Caballos. He is here in the studio with me, and this guy is top-notch. He really knows his stuff. And we've got folks coming, which I'll do the introductions from his company, their chief science officer, and a couple of other folks that are incredibly experienced ultrasonographers that have done a lifetime full of TCD in all types of departments, including the cardiac suite. And I think what we're going to learn here today is going to be fantastic. So we're going to take a short 15-minute break, a little longer than what I will usually do, and we're going to come back. So please be patient, okay? Stay on. And for those of you just signing on, we'll just put up a little thing. You can unshare my slides, or see, I can't see what you're putting out, and we'll, because I can't see it. And just put up that break thing like we normally do, that overlay, and we'll take 10 or 15 minutes, get our act together, and then we'll come back with everybody else and be ready to move forward. If that sounds good to everybody? Okay, sounds good. So stay tuned. We're not going to turn off. We're just going to go to overlay and break. All right, there we go. And of course, that's going to do that.
Oh, that's the blinking you're talking about.
Yeah, I told you it was really tough. It's really tough. Okay, so I want to. I'm gonna just start drinking before this is over. You gotta turn your phone off. It was Mike.
Yeah.
Okay, we're good. I'm gonna stop. I'm not gonna start drinking, but I'm close. Okay. I want to introduce Joshua Renz and Matthew Belando from NovaSignal. Now, both Joshua and Matthew are RVTs, which are registered vascular technologists. Joshua's primary role is as the medical education manager for NovaSignal. And Matt is the senior clinical educator, again, with NovaSignal. These guys are both highly skilled, highly experienced in the field of transcranial Doppler. And with me here today is Mike Caballos. He is the senior regional account manager with NovaSignal. And he has a tremendous amount of experience in the vascular and cardiovascular space, and is a super, super guy. We're hoping we're going to be able to bring in Dr. Robert Hamilton, who is the Chief Scientific Officer and co-founder of NovaSignal. But as I said recently, earlier in the introductions, the NovaSignal is the first autonomous transcranial Doppler system that exists currently in the world. And it has some very unique characteristics that I think we can utilize in cardiac surgery. And just for our compliance purposes, these folks that are giving this lecture today do work directly for and are a co-founder of NovaSignal. However, the program nor myself are receiving any kind of financial support or any kind, I have any financial interest in this company. So those disclosures have been made. And with that said, I'm going to turn this over to Josh, Matthew, and Mike and let you guys go forward. I've got your slides here. So if you want to just say next, we will change the slides for you. And Josh, we're not getting your sound. Matt, please come here.
Hello, can you hear me?
Can you guys hear me okay?
Yes.
Good, great. Thanks. I believe we don't see the slides yet.
They don't see the slides yet. Magic.
There, perfect,
Great.
All right, so this is, again, we're going to be going over transcranial Doppler, give you a brief introduction of TCD. That way you can follow us as we go through and explain the use of this for intraoperative monitoring. And we'll have a few case studies. You can go to the next slide, please. Great. We already had an introduction on thank you for that. That's the three of us here. Again, I won't go into the introductions as we just did that. But both Matt and myself have been doing transcranial Doppler. Continue to do it with NovaSignal. We're out in the field weekly doing these studies and monitoring these intraoperative cases. Next slide. Great. So the first set of slides here will go over transcranial Doppler, a bit of the basics, kind of give you a history and the evolution of transcranial Doppler. Next slide. Great.
Magic, could you turn the volume up a little bit so I can hear it?
Great. So transcranial Doppler has been around for about 40 years now. the 40th year anniversary was just earlier this year. Transcranial Doppler provides a non-invasive method to assess the blood flow of the major conducting arteries of the circle of Willis. It uses about a 2 megahertz probe, and we look at these vessels through the temporal window with the ultrasound gel. I don't know if I have a bit of echo there. I guess we'll continue to the next slide.
Is that supposed to have a video?
No video. There will be one video.
Okay,
further in the
so next slide. Gotcha.
Yeah, great. Next slide. Thank you very much. So when we perform transcranial Doppler, there's 3 acoustic windows that we can use. We can see through the temporal window, which is at the side of the head. We can see through the orbital window or through the eye, and the occipital window through the foramen magnum. So we can assess all the major conducting arteries of the brain. We'll go ahead and go to the next slide. Great. And so transcranial Doppler in the early ages just provided a waveform, which you see below, more or less a typical waveform that you would see on any ultrasound, but this provides us with the basis to interpret the blood flow in the brain for a variety of diseases. What we have here, and this is the technology that's used in the case studies that you'll see, is power M mode. A very basic description is any blood coming towards the ultrasound probe will be displayed in this depth graph, red coming towards the probe and blue going away from the probe. We can kind of look at this like a fish finder. So if there were looking in the water, any of the fish coming towards you would be blue, and any of the fish going away from you, towards you would be red, any of the fish going away from you would be blue, going into the ocean. Next slide. Great, here's a visual of how that works. And so the main artery, the middle cerebral artery, which is coming towards the probe, is displayed as a big red band in the M mode display. And this is important because you'll see the MCA is the main artery that we use to monitor in these intraoperative cases. The power M mode is a very, very sensitive method for finding blood flow. So this helps us find the window. So the window is the area over the transtemporal bone that is thin that we can see through. The color bands helps us identify which vessel we're looking at. And it also accounts for varying head sizes. Because if the head is bigger, the vessel will be at different depths. And power M mode is also very, very sensitive to the detection of both emboli, air emboli, and particular emboli like blood clot. Next slide. Great. This is a description of the transcranial Doppler waveform. Basically gives us the blood flow velocities. And so just as the heartbeat, we can look at the systolic and diastolic components of the blood flow to the brain. We can measure the cardiac cycle, basically one beat from the next. And it also gives us the amplitude of the signal, which corresponds to how many red blood cells there are in these vessels. So that's a good way to more or less give us a sense of perfusion of the brain. Go to the next slide. Pulsatility index is another metric that is provided, which is calculated from the velocity itself. Pulsatility index gives us a sense of the resistance that the brain has to the blood flow. There are normal values range from about 0.8 to 1.2. Again, this is going to be very relevant during these intraoperative monitoring cases, especially. This helps us determine if there is disease proximal to the area that we're looking at or distal to the area that we're looking at. And there's a bit of a correlation with the pulsatility index and waveform morphology, which is describing how the waveform looks itself. Next slide. Great. So waveform changes. One of the most powerful things in diagnostic imaging alone is recognizing normal values or what normal is. And that is very well the case for transcranial Doppler. So as you pictured here, the first image there is the waveform of the middle cerebral artery, and this is the normal waveform. One thing to note is what we call the upstroke is portion during systole, and that is usually straight when the vessel is normal. When there is increased resistance to the brain, we get increased PI, which is pictured in the bottom left. Basically, we get a very sharp waveform. If there is a proximal obstruction to the point we're looking at, we would get decreased pulsatility index or delayed upstroke, which is rounding of the waveform. And these make it pretty obvious at times to describe particular pathologies that may be occurring. Next slide. Great, so applications of Transcranial Doppler, there are many. The list goes on and on. This is just a small portion of it. The advantages of Transcranial Doppler are that it's non-invasive. We can continuously monitor. So there is no harm using ultrasound. It can be done at the bedside point of care, and there is no radiation. For diagnostic testing, some of the most common applications: sickle cell disease, patent foraminal valley testing, and using TCD for subarachnoid hemorrhage detecting vasospasm. And then monitoring, more or less, monitoring can be done for anyone who has a stroke or had a potential stroke. So some of the more common uses are for monitoring for emboli. So if someone has carotid disease, we like to see if they're embolizing from that plaque in the carotid artery. Cerebral vasoreactivity. So this is a way that we can test to see how much reserve the brain has to accept blood flow. And also intraoperative monitoring, which we'll go into more in the next few slides. Next slide. Great. So again, 40 years of transcranial Doppler. Here are some pictures in a timeline of what the devices look like. Pretty archaic in the beginning. Very large computer which provided a waveform to look at, so no imaging. Before this, it was actually just the sound that was used, and so there was no image. They would just use the frequencies and changes of frequencies to determine if there was any pathology. As the timeline goes on, not many changes for the 40 years. We moved from analog to digital, which provides us with more capabilities, but nonetheless, there's not much change in the ability to get the same data from the beginning till more recently. Next slide. Take a look at the progression of automation. So I think maybe about 10 years ago or so, we had robotically assisted devices. So these are ultrasound probes that basically have the ability to angle around once placed in one particular position. And now, today, we have full automation, which was mentioned a little bit earlier, the NovaGuide system, which is autonomous, fully robotic, and has 5 degrees of motion, which means it has the ability to actually move around the head and find the signals. Next slide, please. Great, so current state, so this is what's available today for use. Again, we have the manual robotic headset. Each one of these requires placement of the robotic probe and acquisition of the signal before they're used to actually monitor and maintain the signals. And then lastly here, we have the NovaGuide system, which moves around. We have a video in a bit here that will show you exactly how that works, so you can appreciate the difference. Next slide. Great, so artificial intelligence, everyone's favorite word these days. This is one of the reasons why this technology is so successful. We have the ability to take tons of data sets and apply them to this technology. Kind of a bit more basic way of describing this, like gathering thousands and thousands of patients' data, we're able to calculate and tell exactly where the window will be for us to find the cerebral blood flow. And this information can be used for the robot to make decisions on where to look and how to maintain the signal. Okay. Next slide. Great. Along with advances in technology, computing power, we also have the ability to stream and send all this data to the cloud. And so these exams can now be remotely viewed live during the exam, which was possible in the past, but it was usually very isolated. So this would take a hospital that had a system in place that they could actually stream these exams with probably some latency, so they weren't quite live. But now we have the technology to do that. This really expands the use of the technology. The robotics itself allow anybody to use it, and then the cloud really gives us access to experts and physicians around the world who can watch an exam live and provide help that way. Go to the next slide here. Great, so this is the video. This will show you how the robotic is set up and used. If someone go ahead and start that video.
Trying.
Yeah, no worries. There is.
It's not a video.
Not a video.
It is not. Yeah, it's not a video on my on this. Let me see.
It should be a video.
Let me see. If we can make this work. Give me a second to see if I can figure it out. This is this, and this is slide 17. Let me see. 16, 17. Yes, it is a video. Can we, can you do me a favor? Can we switch to my computer for instead of the iPad?
So then your laptop up there?
Yeah, I have my laptop.
No.
I can't share the laptop?
Maybe if you stop sharing, you might be able to
Okay.
see if we ever try that.
Yeah, I don't know how to do it. So we'll just keep talking, Josh, and let me see if I can
Yeah,
figure
fine.
this out.
That's fine. I can kind of go over what we're seeing in the image here, but this is the NovaGuide robotic system. It's a cart-based system, so that can be transported throughout the hospital. The head cradle and the robots are on the bed, as you can see placed there. That's where the patient will lie. And then those probe pods, where you can see the ultrasound probe, those can move around the full range of the transtemporal area. And so once the patient is set up, we simply just slide those pods. There we go. Got tricked there. But once the pods are pressed against the head, it's fully automated and will switch around. This is really relevant because for the last 40 years, this had to be done manually. And the learning curve for transcranial Doppler is very, very steep and very, very long. On average, it takes about a whole year for someone to be really trained in transcranial Doppler, which requires somebody who's expert at a center to train them during that period of time. It is physically hard to do, and it becomes complex when there's pathology. And the pathology isn't always seen from day to day, so it can take quite some time for you to see a particular pathology. And this is where the pitfalls usually fall. And so the ability for anybody to be able to put on a robotic system, get the data, and then stream that to experts really expedites the learning process and reduces that learning curve drastically. And so what took years can literally take weeks. Definitely not anywhere near as long as it used to be. Still working on the video. Matt,
Yeah, we're not gonna, Josh. We're not gonna get the
No
video.
video?
Just
Yeah,
move,
no-
you gotta
no
move
worries.
on.
Yeah,
This
that's
has
completely
been a
fine.
tough day. I'm sorry.
It's all right. So the video simply just would show a patient lying in there and moving around and finding beautiful signals all on its own. It's easy to describe, so we can move on to the next slide.
And I can
So I'll
speak to
pass
these
it over
too, Josh.
Matt. Yeah, great, thanks.
Thank you, Josh, for setting us up with the basic history of TCD. Here we have a slide that breaks down the risk of stroke for different procedures. So with perioperative stroke, it is the most unwanted complication for patients, as well as for the surgeons and the anesthesiologists. As you can see on this chart, the incident of perioperative stroke depends on the type and complexity of the surgical procedure that's being performed. With general or peripheral vascular surgery, you can see the incidence of stroke is generally not that high. It goes from about 0.1 to 3%. However, stroke may occur in up to 17% for patients undergoing high-risk cardiac or brain surgery. And now that's a pretty big gap there due to the complexity of the different types of surgical procedures. When perioperative strokes occur, it has a significant negative impact on the recovery from the surgery. Patients with perioperative stroke are less likely to have a good functional outcome and have a much higher mortality. Identifying perioperative stroke is a very important and challenging thing to do. The lingering effects of anesthesia may delay the diagnosis of neurological defects in patients. And sometimes the first clue to a clinical suspicion of stroke is because the patient is having difficulty awakening from the anesthesia. And oftentimes at this point, if that's when a possible stroke is being recognized, the neurological deficits may have already been taken into effect for the patient, which just makes the complications even more difficult to try to early identify a stroke and prevent any of the permanent damage that may happen. So I think a key to what we're seeing with these percentages is a delay in the recognition of any kind of neurological deficits that might be happening either intraoperatively or immediately post-operatively.
Hey, Matt,
improvements.
Matt, I'm sorry to
Yeah.
interrupt you. Which slide do you want me to be on? So I want to make sure I'm on the right slide. Currently, I had just left
we're still
stroke
good.
risk.
Yeah, this is still a good slide. I'm just about done with this slide, and then once I'm finished with it, we can move on, and I'll
Okay,
alert
very
you
good. Yeah,
on-
just
on
make sure
next.
just remind me to change it, please.
Sure thing. Thanks, Joe. So improvements for prevention and early diagnosis and proper management of perioperative stroke is an important thing, not only for the patient, but it also represents an area of great public and economic benefit for society, especially considering the aging population that's continuing to grow. So go ahead and go to the next slide for me, please, Joe. Perioperative monitoring with TCD. What TCD can provide is real-time cerebral blood flow information to assist with reducing the incidence of neurological deficits for surgical procedures intraoperatively or postoperatively. There's extensive and rapidly growing literature that suggests the essential hemodynamic information provided by transcranial Doppler ultrasonography neuromonitoring would provide as an effective monitoring modality for improving outcomes for different types of surgical procedures. So with that, what TCD can do is it provides prompt and instantaneous detection of cerebral blood flow changes, embolic activity, hypoperfusion, hypoperfusion, the knowledge of which will impact surgical technique, blood pressure, carbon dioxide control, and medical therapy in the OR and in the post-operative phases. TCD perfusion monitoring detects the presence and direction of the cerebral blood flow in real time. This real-time information can aid in the quick identification of a possible malperfusion cannula. It can detect an inadvertent great vessel occlusion, or it can even just suggest adequate collateralization during any kind of surgical maneuver, whether it might be like a large artery clamping or any kind of abnormal perfusion of flow happening due to the surgical maneuver that might be happening. With TCD continuously monitoring in real time, you're able to detect these abnormal changes to cerebral perfusion immediately and can instruct the OR team to make corrective adjustments before any permanent damage actually takes effect. Also with that, the pulsatility index is another good parameter that you can detect in real time with TCD. And it's inversely related to the cerebral vascular resistance. So what that means is if there's a sudden increase in pulsatility index, This may indicate that there could be a possible venous return compromise. And so simply adjusting the venous return cannula can help improve that pulsatility index and the overall cerebral perfusion. And increased PI, pulsatility index, identified even during post-cerebral perfusion. So after cerebral perfusion has been completed and removed from the patient, if there is persistent increased pulsatility index still being detected by TCD, that could suggest developing cerebral edema, and it could detect that early on before any significant further damages happen to the patient. With TCD cerebral perfusion during intraoperatively used, it can aid in determining the safe upper limits and lower limits of pup flow and perfusion pressure. And a big one that a lot of people kind of, when they first hear about TCD or recognize TCD, is the detection of active embolization. And so this can occur at any point during or after the surgical procedure. And the embolic counts, or the amount of emboli that's being detected, depends on the procedure and the patient risk factors and the intraoperative surgical maneuvers. These will produce shower embolic events, and with the shower embolic events, specifically what we're looking for after these embolic events occur is a sudden increase, which is compensatory, or reduction of flow with a sudden waveform morphology change, which may indicate a large vessel embolic occlusion. And with TCD, the overall benefit of that is we can detect that almost instantaneously when this happens. As long as we can hold a nice clear signal throughout the length of the procedure. If there's any sort of abnormal events like I just discussed on this slide happening, TCD can detect that, and we can redirect a course to be able to prevent any kind of neurological deficits or lack of cerebral perfusion happening to the patient. Next slide, please, Joe. So intraoperative monitoring with TCD is common. Some common surgical procedures performed are carotid endarterectomy, carotid stenting, PFO closures, cardiac surgeries, balloon occlusions, and the list goes on. TCD neuromonitoring is an effective monitoring tool to better understand the causes of the neurological complications during the surgical procedures. TCD monitoring of cerebral blood flow is the only available real-time monitoring technique that can identify embolic activity as well as instantaneous changes in overall cerebral blood flow. Other neuromonitoring techniques are useful and needed with these procedures, so I don't want to say that TCD can replace these, but in a multimodality sense, in these complicated OR cases, using all these neuromonitoring techniques and combining that information along with TCD can really assist in the early identification of inadequate perfusion of the cerebral blood flow vessels. And some tracked events with TCD include instantaneous changes in cerebral blood flow velocities, changes in pulsatility index, abnormal waveform morphology, and embolic events. Next slide, please, Joe. Here are a couple images that represent the use of the NovaGuide machine within the OR setting. And as we can see here, with the autonomous acquisition of the headset, we're able to still place the headset to achieve adequate TCD signals while also having all the other equipment hooked up in the OR. And in the picture on the bottom middle there, we can see that the NovaGuide is set up. There's a cooling cap on the patient. We have a NIRS monitor. We have intubation and central lines, all within the same picture. And with all that, we're still able to maintain quality, adequate cerebrovascular perfusion signals throughout the entirety of the procedure. And now this has been one of the bigger limitations when it comes to implementing TCD in the OR is there's a lot of maneuvers happening and there's a lot of things that occur during a complex surgical procedure that could cause the TCD signal to be lost or the headset itself to be shifted. And the biggest limitation is to reacquire those signals after that. And the trick with that has been having to go back to the sterile field as a technologist to reacquire those signals. Now with the use of autonomous acquisition of the signals, we can stay completely away from the sterile field and still manipulate the probes in a manner that can reobtain a quality, adequate cerebral perfusion signal and maintain constant information, allowing the technologist and the OR team to have real-time data as far as what's going on to the blood flow up to the brain throughout the procedure itself.
So, Matt, can I please interrupt you for just 1 second?
Absolutely.
What part of the world, and since I don't know, was this picture here taken in? You don't have to say what hospital, but what maybe country, state, something?
Sure. Yeah. This particular picture was in Italy.
Italy. And I find what's very interesting to me is here they have their oxygenator reservoir. I can see they're on bypass. They're using a Levanova pump. This is not the perfusionist here. The perfusionist would be somewhere in this area, you know, be on the other side of this fella. But it looks like they have this monitor, the TCD, in the view for the perfusionist as
Yes.
opposed to anesthesia. Is that your experience with the use of the device?
Yeah, every OR setting is a little bit different, and where exactly we set up the TCD machine has been slightly adjusted compared to the other teams that are working in the OR room, and essentially what space is available for us to nestle in and not be in everybody's way.
Well, that doesn't
Fortunately,
look. That doesn't look very. That doesn't look like it has a tremendously high footprint to me.
no, not at all. And that's actually something it's been very useful as far as implementation into the OR setting, is that we've been able to maintain quality signals while also staying out of everybody's way, which is a big step forward with TCD in the application in the intraoperative setting. And if you can move to the next slide, we have a few more representative images that show just different scenarios of where we have TCD continuously monitoring during a procedure. So on the left there, we can see that the TCD workstation is completely moved away, and actually on the other side of all the IV booms and all the monitoring devices, and it allows us to again stay out of the way of everybody while also maintaining these quality signals. And with the workstation itself, it's very easy to spin around, manipulate, flip the screen to different doctors and providers, anesthesiologists or perfusionists within the OR that are interested in the information, would like to interpret to see if there's any adjustments that need to be made. If you can move to the next slide. So on top of having a small footprint in the OR setting, the NovaGuide workstation is able to integrate with different OR software.
Did
With an HDMI cable.
There we are.
With an HDMI cable, we've been able to hook up to monitoring booms and actually stream the TCD information up so the doctors and everybody can see it in the room next to, say, EEG or any other kind of patient monitoring devices that might be hooked up. We also have a live streaming feature to a software application that we use that we can remotely tune in and view in real time what the blood flow was looking like for the patient during the OR procedure itself. So you actually don't even have to be in the operating room or near the operating room to have an idea of what the cerebral perfusion is looking like with TCD. So again, a big step that we have taken forward as far as our TCD device in the NovaGuide is that we're finding ways to efficiently implement this type of technology and information to be able to get this information with ease and transfer it to anybody that's interested in the information in real time. You can move on to the next slide now. And so going forward, we have a couple case examples, but I wanted to kind of open up for any questions after those last few slides before we touch on some use cases and some examples that Josh and I have been a part of.
Okay, very good. Well, we have 12 questions so far. 12 questions that are not redundant questions. So one is the first. I'll just go down the list. What is your experience with the use of a TCD in CV surgery?
CV surgery. Go ahead, Josh.
in CV
was gonna
surgery? That's the question. What is your experience with the use of TCD in CV surgery?
Yeah, I can start.
Cardiovascular surgery.
Yes,
Go ahead,
CV,
Josh.
cardiovascular, CV surgery,
Yeah,
sorry.
sorry. Yeah, I guess I'll start that off. So I've been lucky enough to monitor probably hundreds of these cases, different cases, everywhere from the aortic arch repairs to TAVRs, PFO closures. Being part of the Spencer Labs in Seattle, we performed a lot of research looking at utilizing TCD in a lot of these cases. And from my experience, one with the robotics, and we've done this in Europe, Canada, in the U.S., all across the country. We've been able to successfully, put that on and use it during all these procedures. And typically, one of the things that we see the most are issues with cannulation. So either cannulation or if a shunt was put in during a carotid at times it's either kinked or just not placed properly, and we do see a reduction in flow. That would probably be, at least from my experience, and I'll shoot it off to Matt now, that alone has been pretty significant as far as monitoring these cases.
Yeah, and it's actually it's opening some interesting information that we've been gathering during some of these procedures. For instance, we've noticed that the embolic activity during certain catheter maneuvers or tracking a catheter over the aortic arch, while also understanding patients' risk factors of possible atherosclerosis and also stent deployment. All these types of maneuvers can create embolic activity. And so tracking and monitoring these different maneuvers while also seeing the embolic activity gives us a good reference to see what the best maneuver might be for those particular cases and ways that we can improve it to decrease the amount of embolic activity and possible disruption of cerebral perfusion to the patient during these specific exams. Now, with the large variety of different surgical procedures there are out there, there's a lot of information that you can obtain, and it can really kind of come down to based on the patient's risk factors and what's going on with the procedure itself, specific treatments and therapeutic measures to help improve patients' overall cerebral perfusion by decreasing the negative neurological deficits.
So that's very nice. That really dovetails well into the next question, which is from a colleague, perfusionist friend of mine, who says, because of what you just had mentioned, what do you say to those that argue it already happened? What difference does it make?
Yeah, that's very common. We hear that quite often, especially with embolization, because embolization, especially during these surgeries, adding blood thinners or retrieving a clot is probably something that isn't going to happen. But there are some very important findings with embolic activity. Like once the procedure is done, if the patient is still embolizing, that's a key finding that would otherwise be unknown. You would not know that they're embolizing. And you would identify it during the case, which is important because then they can act on it after the case, and they can continue monitoring postoperatively and treat the patient accordingly. And so I've personally seen that. Once the patient is closed up, there's no reason to have air emboli. So we can really dictate that these are particulate emboli, and then postoperatively they can treat the patient.
Well, there's a follow-up question to that that's not necessarily, it may be indirectly related. Will the device, actually this is a really good question, will the device diagnose what the problem is and give you possible causes? So let's say you have a pulsatility index or you have a decrease in amplitude. I'm trying to sort of add to the question to maybe make it be a little more, maybe a little less broad, but from your experience, do you get any kind of feedback? Maybe that's the way to put it, that this is a signal problem as opposed to this is really a flow problem.
Yeah, so there's a few different techniques when it comes to determining it. What TCD does is it, again, I think something that we got to remember is the real-time information that we're receiving from TCD during these procedures. With stroke, we want to be able to identify immediately if there's any kind of bad perfusion happening up to the brain. And so to touch back on the embolization, it's commonly known now that embolization does happen during these procedures, and we've identified that a lot with TCD. Now, with the action of embolization happening, what we're looking for when it comes to monitoring with TCD is not just strictly, yes, there was embolization here when you deployed this stent or ran this catheter. What we're concerned about is the sudden waveform morphology change or a sudden reduction of flow immediately following any kind of embolic activity, which could suggest a possible large vessel occlusion or lack of perfusion happening up to the brain in one way or another. So to kind of touch back on the last question you asked, does it diagnose? What it does is it indirectly recognizes abnormal perfusion up to the brain, and it shines a light on what could be the cause for it. And now the factors that come into play is what's currently happening during the procedure itself, what maneuvers are happening, and then also take into consideration the patient's risk factors, and if the patient's risk factors could cause any kind of lack of cerebral perfusioning happening up to the brain. And with that information, it can shine a light on what could be the cause of that lack of perfusion.
So they were they to follow up on that. It doesn't give any kind of not verbal but written assessment of anything. It's all interpretation of the person monitoring it or viewing it. Is that correct or incorrect?
That's
Yeah,
correct.
that's correct.
Okay.
There are criterias. There are normal values and abnormal values, and it becomes quite obvious during these cases what the problem is.
Well, I'm going to skip this next question and go to this question because I think this question actually I like really well is, do you offer a simple course for perfusion or anesthesia, and I guess you would have to add nurses in there as well, that can learn how to easily read these signals during a cardiac surgery procedure? Remember, 90% of the people that are watching this program from our audience are either perfusionists, nurses in the ICU, cardiac surgery, anesthesia, nurse practitioners that probably also work in the operating theater. So it's cardiac surgery based. You have to keep that in mind. We don't have, I don't know of anyone here that is from the cath lab or the vascular suite.
Okay. Yeah, and we do offer courses, and there are courses across the country and in Europe that provide this information. We also do hands-on training, and I think that's probably one of the most useful things. And so that you would get the basic transcranial Doppler training, a little bit like what we did in the beginning, but a little bit more intense. And then once you understand how to read, basically ultrasound waveforms, the hands-on portions, actually working with us while you do these cases using TCD, I think that's where you end up learning the most, and that's something that we provide. Again, there's other resources for that very thing.
So it actually asks, what is the support? So, hypothetically, let's say we get this device at where.
Yeah,
I don't want to say it,
Okay,
but
thank you.
we get it, where. And so now everyone's going to want it because where's where?
Right,
It's
right.
in this area. And it comes into the cardiac suite, and we have it hooked up to a patient, and we're going to use it.
Right.
And I think most of us are going to have a basic understanding of what flow looks like. Red's going towards you, blue's going away. You have basic amplitude. You see I know you don't have a video. I have a video, and I'm going to show you that video. I was supposed to do it at the beginning of what emboli actually looks like, but what support is there to say, okay, we're going to kind of hang out with you. We see something and go, what is that? What does that mean? What do we get for the cost of the device?
I can tell you, we just did a 3-day training up in the DFW area. And at the beginning of the training, the techs were like, they were so with TCD. And at the end of the training, they just felt much more confident. They were excited to do TCD exams after that. And we're about to do another training.
Now, you're talking about people that are already trained in ultrasonography.
Yes, they were vascular techs.
I'm talking about perfusionists.
Oh, okay.
3 days ain't going to be enough.
No,
because we're sort of,
right.
you know,
That's where I
we're
rely
not
on these
that
guys.
we're not that smart. So, but
Yeah.
in the operating room, do you come into the operating room and work with us so that if we have a question about what does this mean, we can actually talk to somebody in real time and help us to understand it.
And that's where I rely on Josh and Matt.
So you guys
Yeah.
would come.
We would come, and actually, one of the beautiful things about this whole scenario is the length of these procedures. And so, typical training at any hospital becomes a matter of time and resources of who's available and how long are they going to be available for. And typically, there isn't a lot of time. But when you're in the operating room for 10 hours, six to 10 hours.
I mean, no,
being able to
we're
work-
not. I mean, hopefully we're not. Hopefully we're
Yeah.
not.
Yeah,
Okay,
well,
we're
more-
shooting it up like 4 hours. We got some really good surgeons,
hours. Yeah, that's-
and I don't want to do those cases that take that long or work with those surgeons that need that long. So we try to keep it around
Okay,
4
fair
hours. But you're right. The
Fair enough.
procedures are a little longer. There's usually a lot happening. You have let me not get in my own thing. Let me address the questions that people had. Did you want to say something about that?
Yes, actually, we do provide support for the operating room. Matt, Josh, or a few others on our med ed team could come out and support those cases. We'll go as long as needed to make sure that they feel comfortable. And but yes, we're always there for support. And we're one of the only manufacturers that offer the support that we offer.
You're the only manufacturer that has the device.
That's true.
Okay, so this question seems obvious to me, but I'm going to ask it out of respect to the asker. How does this differ from NIRS? I have a couple of slides, but let me let you address it because it was a question that was asked by by an attendee.
Yeah.
Yeah, so
Go ahead, Matt.
I was just going to say that NIRS and then EEG, they assess. So NIRS assesses the superficial blood flow on the outside of the brain, as far as I understand. And what TCD is doing is assessing the large cerebral vessels within the brain itself, so underneath the cranium. And so there's currently no monitoring techniques that can assess that type of blood flow in real time. So NIRS seems to be an indirect way to determine what the perfusion is actually going up to the brain. And with NIRS, I understand that there may be a delay in the information that you're gathering compared to what TCD can provide you in real time.
Yeah, I mean, I think that you're 100% right. And I do have a couple of slides that I want to show, but I do need to tell my audience and ask them, in deference to time. Of course, we would love for you to call in. I don't know what it is about people not wanting to be live on the air. They would rather text the questions or ask the questions with our messenger service, but that's just the way they prefer to do it. And I'm doing my best to answer them all or to ask them all. This one I think is more complex, but I think it's really a good question. It's from an intensivist, and he is talking about the microvascular scanner that's used to look at it. I don't know if you guys are familiar with it. It's used sublingually, and it looks at the flow through the microvascular system in patients who are septic, and it can show those microvascular perfusion deficits or hyperdynamic. There's all kinds of shunting, all kinds of things like that. Does this play any role in the intensive care unit with either, and the question was for ECMO patients on high-dose pressors and or patients who are septic? and have perfusion, odd perfusion characteristics as a result of that?
Yeah, so the use of TCD in general for any concerns of perfusion issue has been well established over the last 40 years. ECMO and sepsis, I wouldn't say they're routine uses, but one of the reasons they're not routine is because of the ability to do transcranial Doppler in any institution. You don't usually have the resources for someone to see a patient who's septic, maybe, or on ECMO. They're usually kind of bound to doing other services like EEG or vascular Doppler, and those usually take precedence over many of the other transcranial Doppler studies for many reasons. But anytime there's a concern of any perfusion deficit or over perfusion deficit, transcranial Doppler can be used.
Well, do you see a relationship between, sometimes when, of course, a patient is septic, you'll see very low blood pressure, high heart rate, cardiac output is actually uber high, but you have a loss of vascular tone, and so your microvasculature is very deranged. Is there a relationship between that microvascular derangement and the macrovascular flow through the cerebral arteries, in particular the MCA that you would use in the case of this device?
Yeah, I mean, it's a bit hard to answer, but I can say that you can test the autoregulation. You can test the vasomotor reserve system. There's a couple of ways to do this. There's a very easy way to do this, which is a breath holding index study, where you simply have the patient hold their breath, and you can assess whether or not they are passive to their blood pressure, basically whether or not their vessels are fully dilated or maximally dilated. The reserve is full.
And that's the pulsatility index he's talking about. Is that the pulsatility, the PI you're talking about?
The PI gives you an indication that there may be maximal dilatation of the vessels. That's a very fair assessment. If you have a fully dilated cerebral vasculature, the pulsatility will be decreased because the diastolic flow will rise during the cardiac cycle, and so that is an indicator. But with this vasomotor reserve testing, we either give CO2 or we build CO2 up in the body with the breath holding, and that shows us how the small vasculature reacts to an increase of CO2. And simply, if there are no changes, that indicates that the vessels are maximally dilated, because CO2 should dilate the vessels more.
Okay, and just a few more questions that we'll do before you go on, and I also want to show you a couple of slides. In fact, I'm going to show you my slides before we go to your slides, because I think that that might answer some of these questions as well, and sort of help dovetail into your case examples. Can you detect gaseous versus particulate emboli? I know I've asked that question before. I've asked it, but our audience would like to know.
Yeah, I can answer that. So there is some technology that tries to, and I say try to because it's not as sensitive as one would like for practical use. It's often used for research. But one of the most powerful ways we can distinguish between these two is purely based off of what is happening at the time that we see them. And so if you do an easy example is if you inject air for a right to left shunt study to look for a PFO, that that's air, right? And when you inject it and there's a PFO, that you'll see it in the brain in about 3 heartbeats. And if you didn't do an injection and you saw emboli, it's an assumption still, but it's a very strong guess that those are going to be particulate emboli, because there's no reason for there to be air.
Right, but keeping this in the within the context of cardiac surgery, where you have a lot of manipulation of the aorta, cannulation. You've got patients that are, vasculopaths, they have atheroma, they have calcification, you have the pump, you have air, you have all these things happening. Is there any recognizable difference in the, let's say, the velocity of an embolic event that occurs, which would lead an experienced sonographer or person involved in this that could say that is likely gaseous, that is likely embolic, because I would think that, or likely particulate, because I would think gas would move faster. Like, is there anything that tells you that on the signal that you get?
Yeah, that's a great description. So air emboli are very reflective, and you usually have a very, very strong signal. And so when you show your slides, and Matt had some emboli up in the previous slides, but basically you get this white streak. And air emboli are always very, very bright, which means the amplitude's high and the reflection of the actual air bubble is high. If you did a carotid endarterectomy procedure and you pulled out that carotid plaque, what happens is there's new plaque that grows over basically the wall of the vessel that was taken out. There's 3 walls, and they take out the intima. So a smooth layer of plaque grows along that wall that was taken away, and that plaque you'll see break off, or small pieces of that clot, let's call it, you'll see break off, and they're visible, but you can tell completely the difference between air and that particular emboli.
So
there's contrast injection. So if you did a contrast injection, it looks different than an air bubble injection and real emboli breaking off. Definity, which is a lipid-based air bubble that's covered in lipids, they use for enhancing imaging, for echo. That looks different as well. And so there are differences. I think if you're experienced enough, you do get a very strong sense that these are probably not air or gaseous, and you're concerned. That's something that we would bring up during these cases. You can also look at the transesophageal if it's not collapsed, and you can see any of the chambers of the heart, and you can see air bubbles.
Oh, we see massive amounts of air when we do a valve. I mean, we have massive amounts. I mean, and those patients, of course, looking at the data, and you showed the data earlier, we want to believe it's benign, but we know it's not. So, I mean, those are very good. Of course, we get the obvious questions from people. I don't know if you want to answer it today. You guys can if you want to. If you don't want to, I totally understand it. But they want to know what the cost of the device is, and they want to know what the cost of the disposables are, or the per case cost. If you want to discuss that,
I would say
you can.
Contact your local sales rep. If you're in the Texas area, that's me.
Okay, that's fine. Okay, so, I mean, but it's a legitimate question. People are going to ask. They want to know, and we'll go from there. Let me ask you this. Is it so much money you got to take a loan out?
No.
Okay, very good. So I do want to show you my slides real quick, and I think both Josh and Matt, there are like 4 of them. They're very fast. They're 5. I hate to say it, my video is going to work because it transferred over. I apologize your video didn't work because I think your video is really cool, but that's okay. We'll deal with it. Can you go to my slides? And just let me know when they're up because I can't see. Okay. So what do we perfuse? And this is a classic perfusionist. You see the very small brain. And of course, I asked the question, TCD, should it be a standard of care? And of course, I always mention Bob Groom because I think he did so much work with cardiac surgery. And I know a couple of cardiac surgeons. Ari Blitz is one of them, who is a wonderful, fantastic cardiac surgeon who would not do cases without TCD, but the old style. So it was very labor intensive and hard work, but he really felt it gave him some real good data. But what do we perfuse? The body as a whole, the limbs, the heart, the kidneys, the liver, the gut, but what about the brain? And there are trillions, 100 trillion stars, trillions and trillions of them in the Milky Way. And there's in fact that many neurons in our brain. And you lose a lot of brain when you lose blood flow going to it. You lose a lot of synapses, a lot of neurons. It's a very bad thing to do. How do we, however, measure adequacy of perfusion when we're doing cases? Now, we'll talk about NIRS very quickly, but we assume a whole lot. We use some fancy calculations. We measure SpO2. We check the lab and the acid-base balance. We measure DO2. And we look at cerebral oximetry. Well, I'm going to very quickly tell you about cerebral oximetry. Here is a cerebral oximetry of the range that you can get from patients who are alive. If you're dead, you can still get a cerebral oximetry number. And if you're dead, hopefully beforehand, and we remove your brain, you can still get a cerebral oximetry number. And there was an article, a paper written, I can't remember the author now, called...
Watermelon?
No, it was called Patient or Pumpkin.
Right.
And if you put a NIRS on a pumpkin with a candle in it, you'll get a reading. So live patient, dead patient, and evacuated cerebral cavity patient, no brain at all, perfusionist, will have a cerebral oximetry number. I have to say this is just very important, I think, to hear. There is no good stroke. Perioperative stroke rates in cardiac surgery range, and when I say perioperative, periprocedural, range from 1.7 to 2.9%, depending on what study, but that's about where it's at. In my view, that is too high. Encephalopathy rates, however, range from 7.7 to 13.8. And those patients with that brain fog, frequently it's very hard to diagnose. There's subtle changes. Uncle Bob doesn't seem like Uncle Bob anymore. The patient could be combative postoperatively. There's delays in extubation, longer time in the hospital. And those encephalopathic rates tend to be, from my experience contemplating this, generally a hypoperfusion kind of episode, not necessarily just embolic. Right. And when you go on bypass with cardiac surgery, there are times when you're really struggling to get the blood pressure up from 30 to 40. Or to get it up to 50, and you're giving a lot of vasopressors, vasopressin, Neo, Levophed, Norepi, whatever the case may be, to try and get that blood pressure up, but you're also running lower flows. There's a lot going on, and so if we worry about the kidney, oh my God, are we making any urine? Well, what about the brain? The brain is the most sensitive organ we have to hypoxia and low blood flow. Right. The kidney is an important organ. You don't want to live without it. You can, but you don't want to. The heart, really important organ, and myocardial protection is very important, but the most sensitive organ is the brain. We've got to really start focusing in on that a lot more, because the encephalopathy rates are extraordinarily high, but stroke rates are also too high. So I'm going to play this video several times and just talk through it very quickly. What I want you to look at is the top left here. It's a little blurry, but what you're looking at is those real bright white lines that Josh was talking about earlier. What I want you to look at here, and it's just going to repeat, here is the arteriotomy. This is an off-pump cabbage. I'm going to start it again. Here is the Mr. Blower, right here. And here is the stabilizer. Oh, sorry. Oh,
This is the case you were talking about.
And here is the stabilizer. So here's the arteriotomy. Here is your cerebral blood flow going through the middle cerebral artery. And as you watch, you suddenly see right there, all those reflections. And what I want you to do is simultaneously look right here. See the Mr. Blower? I'm going to let you watch it one more time. Bleeding out of the coronary, coronary being cleared, reflection of gaseous emboli. Think of the MCA as a target organ to be protected. So what is happening? Well, I'll tell you exactly what happened. I'm going to stop it right
there.
Here.
Yep.
You see the first little reflection, and look at the Mr. Blower. It is blowing in the coronary, up the coronary, out of the coronary ostia in the aorta, and straight up to the brain, to the middle cerebral artery. There it is. This is Dr. Ramchandani's case at Methodist, and they were using your device, the Nova Signal, at the time this was done.
That's a good finding during surgery.
And that shows you that just because you're off pump doesn't mean you can't do something, because having seen that, you're going to definitely change maybe the angle of where that Mr. Blower is coming in. Instead of pointing it towards the proximal portion of the coronary, the more distal portion, turn it down, farther away, don't use it at all.
So what did they do when they saw that?
Well, it took them a couple of times to figure it out.
Okay.
They were like, well, where did that come from?
Right.
And then they did that again. Well, where did that come from?
It
took them a couple of times to go, wait a minute, every time I do this, that happens.
Right.
You learn. Because had they not been monitoring cerebral oximetry, if they'd not been monitoring TCD, we'd just go on fat, dumb, and happy. And do you know how many times? Very rare that anybody uses off-pump coronary anymore. There's a few surgeons that still do. Dr. Ramchandani's one of them. But I can assure you, he changed his practice.
Right.
This
that makes
taught
sense.
him something. So, there are known knowns. That is to say, there's things we know that we know. And there are known unknowns.
Right.
That is, there are things that we know we don't know. But the most dangerous of things are the unknown unknowns. There are things we don't even know we know, and that's what I think TCD offers us. That's it. End of my slides. Let's put his back up. And we'll go to case presentations. And from current. And we're back up. Those were my slides. And that's sort of how I feel about this whole process of what we're doing here. We simply don't know. We have very easy ways of knowing if we are protecting the myocardium. I can look at if we're giving cardioplegia, it should be asystolic, right? It's not going to have anything. When we take the clamp off, I can look at the heart. The heart is beating, but ain't beating great. And I look up at the EKG and the ST segments are elevated. We probably have air in the coronary. I need to drive the perfusion pressure up, blow that air out, and it gets better. Or one of the grafts isn't very good, and might have to redo the right coronary or the LAD or whatever it might be. But we can see it. There's an immediate sign, right? You can look at the kidney. I can look at metabolites, the creatinine level, look at the urine output. I can treat it with some Lasix. Did I get a reaction? Probably kidneys are probably okay.
Right.
Liver's probably going to do okay no matter what until later. You know, having hepatic failure is a completely different problem here. But the heart and the kidneys. Even with cerebral oximetry would never have noticed that problem. Not at all. But that problem really did exist. And I think that's just
an awesome example.
Yeah, it really is. And cerebral oximetry is looking at the blood flow in the skin, the bone, the underneath the bone, the mixture of arterial and venous blood. So it's taking all of that into account. And if you have enough hypothermia, maybe, or whatever, you know, enough of your cerebral vascular system open, you're probably not even going to notice any change in your cerebral oximetry numbers, but you could have embolized and not have zero flow through, you know, one of your right MCA and not even know it.
Well, and now with the robot, you can see if you have flow and what the velocities are.
That's what's critically important. I think there's such a difference in this. But anyway, well, let's go on with your case presentations, guys. I'm so sorry. I hope those slides added some value.
Oh yeah, most definitely, and we can proceed to the next slide. I think that was a great segue into this case. So this case is an aortic arch repair that was performed in Liverpool, UK. The doctor there, the cardiac surgeon who's performing these procedures, was trying to figure out a way to help his patient. So he had a patient who committed suicide due to postoperative delirium, and after that, it was kind of the last line for him in his quest to figure out what he can do during these procedures to limit something like that happening, as well as trying his best to prevent stroke as well. And so it's been long known that cognitive dysfunction after these procedures has been a big concern from aortic surgery. But postoperative delirium, acute sleep update, is something that has been recognized more recently. We see about a 9% risk of stroke during these long aortic arch repairs, and in Liverpool, they're experiencing about a 30% rate of delirium. I don't know what the national averages are. And I don't know how well those are taken into account for, but they've done a good job of that. And again, they decided to use Transcranial Doppler in order to prevent some of this stuff. Go ahead and go on to the next slide.
Yeah, I would say those numbers, just for, you know, for the sake of discussion, are pretty consistent, you know, in worldwide in first world, you know, cardiac surgery centers that are doing aortic surgery. A 9% stroke risk is pretty reasonable, probably maybe a little low. Sounds like this guy takes a lot of care. 30% of the delirium rate, I think, is also very consistent with that type of operation. I mean, a big, like an acute aortic dissection, you've got a much higher risk of stroke than that. But 9%, 30% seem reasonable.
We did this earlier, but just to give you a sense of actually using the robotic system during this procedure, you can see that a cooling cap is used, NIRS, and pulse oximetry of the brain. So all this
here's
stuff.
The cooling cap. Here's your NIRS. Here's your BIS. Here's your robot, your trans TCD. Here's your patient is intubated, and here's your central line here.
Yeah.
So you've got a lot.
Yeah, there's a lot there, and it actually fits quite well in there. The central line may require an extension. To date, that's really been the only adjustment to the patient or the area that we've experienced. So we can go ahead and move on to the next slide. So during this case, the bilateral middle cerebral arteries were monitored throughout the procedure. And to give you more clarity, we can monitor the posterior circulation as well. Typically, we're more concerned about the anterior circulation, but with the robotics, we can actually navigate between the anterior and posterior hemisphere, as well as the contralateral side. So in Liverpool, they do perform lateral cases. They've adjusted their system to be able to do so. And they will actually, because of the sensitivity of the power M mode, we're able to monitor the contralateral side. So you can go clear across from left and see the right side, or you can see the right side from the left side. But routinely, we monitor the middle cerebral arteries. The majority of the blood flow will go to that hemisphere of the brain. This way we can capture as many emboli as possible, as well as any significant flow changes. And so one of the most powerful things for these cases is to establish a baseline. We can establish a baseline during multiple parts of the procedure. And so we like to get one preoperatively. So this gives you, it establishes what is normal for the patient. And so not all these patients will have normal blood flow. In this case, as you see in the first image, those are completely normal waveforms in middle cerebral arteries. So we'll establish, again, a baseline prior to the procedure. And this doesn't have to be done before the patient's on the table. It can be done on the table. It just needs to be done before anesthesia. And then, again, we can establish a baseline before any significant part of the procedure, such as cannulation, cardioplegia, etc. The second image here is used to establish a baseline during bypass, as well as the last image, which gives us the baseline during hypothermia or of the patient, which in this case was done to 22 degrees. And you can see the flow velocity dropped about 50%, probably 40%.
43 to 20.
Mm-hmm. Yeah, on bypass.
Yeah.
Yeah, and for further clarity, a decrease in the velocity does not mean there is a decrease in perfusion. One of the things that the power M mode gives us is amplitude, and amplitude indirectly gives us a sense of the perfusion. It doesn't give us an exact number, so we don't know quantitatively what the perfusion is. But again, we establish a baseline. In this case, we have very bright signals which correlate to normal perfusion, typically, and we know this because the patient is normally perfused before procedure with MRIs, et cetera. And so we establish that as a baseline. If that signal, being that everything stays the same, as in the patient isn't moved, or the signal is moved, that signal itself clues us into that there may be some significant changes in the perfusion itself. We can go ahead and go on to the next slide. Great. So the first image is during cardioplegia, so the heart is stopped, so they can perform cannulation. As expected, we have no flow to the brain during this point in time. Once the innominate artery was cannulated, we see flow restored to the right middle and anterior cerebral artery. So this is on the right side of the screen on the second image where you see the red and blue. There are some most likely air emboli during this part of the procedure, as we expect air to be introduced into the system once these cannulas are placed. But interestingly, what we see is the left side of the brain is only being perfused to the anterior cerebral artery, not the middle cerebral artery itself. So that red band that you see in the last image on the left side of the screen, where you see the emboli going through, so the larger white streaks, that is the portion of the signal that's the middle cerebral artery. And you can see that is absent during cannulation of only the right, or the innominate artery on the right side. And so despite flow going to the ACAs, it doesn't necessarily mean there's connection into the middle cerebral artery itself. And so we can rely on cannulation of just one artery if there's enough collateral in the brain to provide flow to all of the vessels. And we can see this real time. We can tell if the brain is adequately getting blood flow to it during cannulation. At this point, we know that the cannula to the innominate will not provide flow to the right MCA. And so cannulation of the subclavian was initiated to restore flow to both MCAs. This cannula was placed, and interestingly enough, again, there was still crossover. And so as you can see, the red and blue signal represents the MCA and the ACA. You should see that on both sides. So on the left side, the ACA is coming towards us, which means it's reversed. So competitive flow or something wrong with the cannula is causing crossover. So it's causing the right side of the brain to actually help or provide flow to the left side.
If you have an intact circle of Willis, you know, I mean.
Right.
Exactly. if you have an intact circle of Willis. And this is one of the reasons why NERS is possibly not the best surrogate to determine how well the brain is perfused, because you actually have what's called peel collaterals or leptomeningeal collaterals that form. And so these are at the surface of the brain. And so you could have an occlusion of an artery and still have perfusion via these smaller collateral pathway, but they may not be adequate. And especially over a longer period of time, the longer you have less flow to the arteries in a low flow state, the more likely you are to have delayed ischemia. And this occurs. So the ability for us to tell that an artery is compromised lets us know that there's a potential for that. But it also gives us the ability, it gives this whole surgical team the ability to figure out what the cause may be. And so we can proceed to the next slide. Great. So once that was recognized, they adjusted the cannulas. And I can't tell you exactly what they did, but they adjusted the cannulas, and normal flow was restored to both sides of the brain. So now you can see symmetry between the two sides. You see the red and blue bands. Those are all the vessels as they were pre-procedurally. And so flow was restored. They continued the procedure post-procedurally. And so this is after they repaired the aorta and they've sewn the patient up. We see a significant difference between the sides. And so a couple of questions back, someone was asking, are there clear-cut outputs from the machine that, that blatantly tell you that there's an issue? It doesn't print that out, but there are very obvious changes, and one of the biggest changes is just the ability to look and compare one side to the next. And so you can simply see here that they're completely different, and that the right side is what we call dampened, and that the pulsatility has changed to 0.4, and again, normal is about 0.8 to 1.2. And so this was something that would probably be not caught without doing transcranial Doppler monitoring, as it's not routine to perform vessel imaging after these procedures. That typically is only done if someone is symptomatic postoperatively, and even then, they're typically not going to rush somebody off to CTA. If you're lucky, you may have TCD in that institution, and you'd be able to scan the patient. But this gives the whole team the ability to know that there now is an issue on the right side. And this could likely be in the carotid artery, because we have damp flow, which suggests a proximal obstruction. And so this is a perfect example of why transcranial Doppler monitoring is important to be used during these procedures. Again, in this institution, their goal is to use the blood flow velocities to determine what rate the pump runs at during the procedure. And so they actually tailor that rate based off of the blood flow velocities. Sounds like the video may be working. So this case, again, it demonstrates how we can actively watch the blood flow, see if there's any changes, and alert the team so that they can quickly see if there's anything obstructing the flow that they can change. And then I think we have a few more cases, but more than happy to take any questions about this.
Yeah, the only question that I got on this section was, do you keep a record? One second. Is there a permanent record of the entire file for use in the EMR?
In the EMR, so there, yeah, it doesn't directly input data into the EMR. There are systems that it can communicate with. So there's Moberg, ICM Plus. There's a few multimodality systems that we can integrate the NovaGuide system into, which then would be incorporated with the EMR. It is possible to work with other systems that I didn't mention, and then the NovaGuide itself will be updated. We have updates regularly about, I think every 6 months or so. So we're due for an update, and that does include the EMR. Again, I think, as Mike said, you can maybe contact, you can contact the company and we can give you more insight into exactly what that will
So,
provide.
but
We do
is
have-
there a permanent record of this? In other words, you do a case, so you use it. Let's say you use it routinely on every
Right.
case. Is there a file that is saved anywhere so that if that patient later on has some kind of a problem and somebody says, well, you know, did we have any problems when we were on pump? Did we have good
Right.
flow? You know, were there any things that occurred that
So-
there is a physical record of it?
I believe with our NovaGuide View app, there is. We can save the entire study with our NovaGuide View app, and then also, yes, screenshots can be sent to PACS system and video clips, and they're saved in the NovaGuide View as well.
So only screen clips. So when we do,
I think that's more of a limitation on that system, which is one of the reasons to get our NovaGuide View, so you can see the entire video, versus PACS, I believe, only takes a certain segment of video that will only upload into their
right?
system.
Because I would want to see,
Right.
I would want to have, I mean, that's it's a great question, because I mean, I'm thinking about it too. That if I'm using this technology and I use it as a case, and later on somebody says, you know, this patient had the patient thinks they had a neurologic problem.
Can we take a look at the video?
I can see, I
Right.
can show you, well, here we are on pump. Here's the pump period. This is my time that I took care of this patient. And I know that there was a good flow bilaterally, MCA left and right.
Right. The NovaGuide View would be able to show the entire video.
Yeah.
Yeah.
And the other, what we also do is we have what we call bookmarking events. And so for each particular procedure, we actually write a custom protocol, more or less. And you would mark each event that happens. And all that data is saved into the system. There are several different ways to output it. One of them is a standard CSV or Excel file. And that gives you hundreds of seconds of data. And so if you sync the times up with, you know, the other machines, you have a very good account of what's happened throughout the procedure with the bookmarking or event markers that show you each part of the procedure. And so that's another option that's provided.
Okay. All right. Well, let's move on to perioperative monitoring during aortic arch replacement. That's always fun.
Yeah, very complex style of a surgery, that's for sure. So with this case, this was a 68-year-old male with a complete aortic arch replacement due to a type B dissection. And an interesting complication, well, I guess not complication, but variant to this particular case was there was a aortic arch variation where the right subclavian artery originated off the left side of the aortic arch and traversed back behind the esophagus to provide blood flow to the right common carotid artery and the right subclavian artery. And because of this, selective cerebral perfusion was necessary. And with TCD, we monitored the middle and anterior cerebral arteries throughout the procedure, closely tracking any changes or embolic activity. And with the cannulations, there was ascending aortic cannulation and then bilateral carotid cannulation for cerebral perfusion. And on the right, it gives us an idea of the setup, which I'm sure a lot of the people here viewing this are familiar with.
So here's your drainage for the drainage into the pump, and then what you have here is you have the innominate artery cannulated, and you have the left carotid cannulated, and it looks like they have put a clamp across the left subclavian.
Right. And now this is just a generic photo of what kind of the typical case would be with normal anatomical variation. With this particular patient, since they did not have a right
I
phenomenon.
see, right here.
Yeah,
they had this weird
yeah.
little deal going on here.
Yep.
Yeah.
Yep. And so what they ended up doing is for systemic perfusion, they cannulated the ascending aorta. And then for cerebral perfusion, they did bilateral cannulations of the right and left common carotid arteries because there was no innominate artery due to the anatomical variation.
Yeah. Yeah, that's pretty weird.
Yeah, a little bit different. Go ahead and move to the next slide. So like Josh's case, baseline TCD values obtained before perfusion bypass. These baseline values will be used as a reference for identifying sudden changes in large vessel cerebral blood flow. This is always a good value to have before and then use as reference after the procedure is completed. Just like with Josh's case, there was a notable difference in the bilateral waveform suggesting obstructed blood flow to one side of the brain. And so with this TCD values or these baseline values, they could be used as reference and quickly identify any kind of abnormal blood flow during the procedure itself and then immediately post-operatively as well.
I have go ahead. I'm sorry.
Sure.
No, you go ahead.
Okay. Cardiac arrest on the image on the right side of the screen has been achieved by circulation is now being done with perfusion bypass via the ascending aortic cannulation. This again will provide systemic perfusion for the patient, but at this point in time, cerebral perfusion still needs to be assessed, and so bilateral carotid arteries still need to be selectively cannulated. So if you can move on. Actually, Joe, if you could check really quick. These are little mini videos. There might be, if you scroll your mouse over the image, you see a little play button pop up.
There are. Yours work.
Go ahead and give that a shot. Great. So this is the baseline 4-second image of what it looks like. And then if you play the next video, this is just as cardiac function is diminishing and perfusion bypass is taking over. And the patient is also being cooled during this time as well.
So I have a
next slide,
question
please.
for you. Yeah, I have a question for you. Why is this appear to be a more white? Is this a viscosity issue, or and this one's darker?
Basically, that means a stronger signal.
That's all that means. Stronger signal. The white is strong. Which is stronger?
The brighter the color, the stronger the signal.
Okay.
And these signal, the brightness of that signal can also be adjusted on what's called a gain adjustment.
Okay.
And so
that's not
also
relevant
happen to-
clinically. That's not in this case. There's
Not
nothing
so much. It just lets you know you have a really good signal at that angle and depth.
But you can reduce the like if you want the colors to be, the same. You can adjust that gain and make an adjustment for that. Will that affect the seeing anything that shouldn't be there?
I don't think it should affect anything.
No.
Okay.
No, actually, the if the gain is turned down a little bit, it makes it a little bit easier to identify the bright streaks of emboli that are coming by. Again, this was just a baseline signal, so the amplitude of those M modes are important to see if you are obtaining a quality signal or if adjustment is needed. Sometimes if you do see the amplitude diminish, it's simple as adjusting the angle of the probe to get a better angle of incination to be able to receive the blood flow. But to really kind of get an idea of the perfusion, if you look at the spectral waveform and those mean velocity flows, that really gives you an idea of what the perfusion actually is at that segment of the vessel that you're listening to.
Okay, very
So
good.
you're using both the spectral waveform and the M mode to help determine the overall perfusion. It's not just one or the other.
And in this case, so this is the spectral, the top, and down below is the flow.
Exactly. Yes.
Okay, like I said, we're perfusionists, man. Come on.
Yeah.
Do you want me to go back and show you our brain? Okay, we'll move on. Okay.
So this is the moment in the procedure where the right and left common carotid cannulations were happening. So selective cannulation. The below images show large changes in the right and left middle cerebral artery velocity spectrum during the cannulation process for cerebral perfusion. So these two video clips here are very interesting in the sense that this is a very sensitive part of the exam where you're establishing cerebral perfusion. And so when you click and play these videos, it's showing the exact moment in time where the cannulas were turned on and began providing cerebral blood flow. So like Josh's case where they were placing the cannulas, you see that there's no blood flow up to the brain, but as soon as they turn on that right carotid artery cannula, you can see that influx of blood flow immediately and determine whether the direction or collateralization was happening. And also within that, you can see some emboli streaks going by, which are likely air emboli due to the cannulation. And important at this particular moment of the procedure is to determine that there's adequate stable perfusion throughout that can be obtained throughout the rest of the procedure itself. And so if you go to the very right video, what happened shortly afterwards is we noticed a little bit of asymmetrical perfusion from one side to the other. So the right side had a little bit elevated perfusion, which is concerning for hyperperfusion. And that kind of goes down to where the patient's at in the autoregulation process of the brain and how well that brain is receiving that cerebral perfusion bypass.
Let me get this up, and I want you to talk about that for a second. Let me pause the video, if I can get it to pause. Okay, there. Maybe I just need to blow it up. Okay. Okay. So, so let's go over this. You know, when you say you noticed some asymmetry, where am I looking?
On the top of the screen, you'll see a 13 mean centimeters a second versus a 37 mean
I
centimeters
see that.
a second.
I see 13.
Right, so
Okay, 13 and 37.
Yes.
So there we go. So there's one side, there's the left side, left MCA, right MCA. Yes, now I clearly see what you're talking about. Right. Here you were talking about this big, in this image that's in the center of the screen, that hyperemia you were talking about.
Now that's just the initial influx of the blood flow.
Okay.
And so imagine the brain just moments before that cannula was turned on was receiving zero blood flow at all.
Right.
So the brain is likely at that point saying, hey, there's no blood flow to the brain. I'm going to expand my vessels as wide as I can get them. I'm going to do whatever I can to be able to get blood flow up here because this is obviously not a correct thing to be happening for the body. So when that cannula is initially turned on, it comes down to the flow rate that's happening from the cannula and how much that brain is going to receive blood flow at that point in time. Now, when that cannula is turned on, that's when we can notice maybe a little bit of autoregulation of the brain setting in by the brain saying, okay, I'm getting blood flow again. We need to stabilize this blood flow so we can adequately perfuse this organ, and it'll adjust accordingly depending on the patient's specific situation.
Gotcha.
And
That
so,
makes a lot of sense. And here what we're seeing is this flow in the left side much lower than the flow in the right side. The signal itself looks obviously very different, and the velocities are obviously very different.
Right. And so essentially immediately afterwards, having a little bit of an increase in blood flow isn't necessarily an abnormal urgent thing, but what we want to prevent is long-term hyperperfusion causing abnormal effects to the brain over a long period of time. And so it was communicated to the OR team that we are noticing an asymmetrical difference from the right side of the brain to the left side as far as perfusion goes. And we spoke with the perfusionist to see if there's any type of pump adjustment to help prevent that hyperperfusion setting in on the right hemisphere. And if you go to the next slide, it'll show the stable perfusion blood flow.
Push play.
No, I have to keep going. There you go.
There you go. So now you can see that the right side has gone down and there's a lot more symmetrical blood flow
Yes.
from one side to the other.
Yeah.
And I have to pause it is what I have to do to make it so it doesn't just shut off. So there you go. So yeah, so now 19
Perfect.
on the left, 15 on the right, much more, you know, almost equal or more equal certainly than they were. That makes a lot of sense.
Right. And so even on the right side, how we see on the M mode on the bottom there, it looks like that is almost like a weaker signal. What was done shortly afterwards is just a slight repositioning from the NovaGuide machine itself, not having to go up to the patient at bedside, but we actually repositioned the signal to be able to get a better signal in the M mode itself. But what we can still gather from this information is that the MCAs are both normally directed, and so are the ACAs with the red and the blue. And then being able to monitor the mean velocity of both right and left and keeping them symmetrical lets us and the OR team know that throughout the rest of this was a 6+ hour procedure, that there is adequate perfusion happening to the brain that's uninterrupted and remaining stable the whole time.
And I think that is a very important point that I think you should bring up is that you have that ability to, let's see if I can get this slide to stop doing this. I'm sorry. You have the ability to make micro adjustments to the probes from the control deck. You don't have to go up to the head and make adjustments to the angle of your probes. Is that am I getting that correct?
You're getting that 100% correct. So basically, the robot's going to find the temporal windows and the MCAs automatically, and then the operator can just make micro adjustments on the screen versus having to actually hold the probe next to the head.
Right, gotcha. Okay, let me let you wrap. I'm so sorry to do this, but just we have time constraints. So let's go ahead and get through all the slides. This has been an incredible. We probably should have spent 2 hours on it, but I do want to finish these slides because I think there's some just incredible information here.
Yeah, if you go back one slide, that's actually the final slide for that case. So this is, oh, one more slide back, I'm sorry.
Mm-hmm.
This was a point in where we're nearing the end of the case, and they're removing the clamps and reestablishing blood flow up to the brain while they're removing the perfusion bypass. And so if you play the video that says left carotid clamp, we can see the moment in time where that clamp is applied, and we can see instantaneous changes to blood flow. So right at the end of that 4-second clip there, we see on the left side that there's an immediate drop in blood flow and change in the M mode presentation.
This is, let me pause it. Let me do it this way. Tell me when to stop.
Right.
Stop.
There.
Right there is good. So we can see on the M mode on the left MCA there that the red and the blue completely disappears as soon as that clamp is placed. And actually, an interesting finding here is at the end of that blue M mode line, we see a streak of red suggesting that there could be collateralization instantaneously happening. And on the right MCA, we actually see a little, just at the very end, a little decrease in the amount of blood flow happening to the right MCA, which could suggest a type of collateralization process where the pressure in the brain is different from one side to the other. And so due to the pressure gradient, the blood flow is going to go from a high pressure to a low pressure. And since that left MCA or the left carotid artery was clamped, there's less pressure in the left MCA. So blood in the right side of the hemisphere is going to start shunting over to the left side of the brain to provide that flow. And if
So
you
we're
go to the
talking
next
about
slide,
right here. You're saying right here
Correct.
in this spot and
yep.
in this spot correspondingly.
Well, if you go up to where
Or
the
over-
spectral waveform is,
Okay,
go
up
up
here.
to where there is where the clamp is placed, but on the right MCA, you can see how there's a slight decrease in flow
Right
at
here.
the very end there. Yeah.
Right there.
Yeah.
And so that's suggesting that there is collateralization happening almost at the same exact point that that carotid clamp was placed,
Gotcha.
which is essential information, quick information that we can get immediately with TCD during a sensitive maneuver like this that's affecting the cerebral perfusion. If we go
Okay.
to the next slide, or the next video, it shows a video clip 2 minutes after this clamp was placed. We see that there is perfusion back to the left MCA.
Joe, we lost the slides.
We lost the slides. Okay.
How did that happen?
Probably me. Hold on. I'm resharing with the iMac. Okay. Slides back. Okay, there you go. Sorry about that, guys.
Now that's okay. We're seeing perfusion to the left and the right MCA, both symmetrical now. What we see on the left MCA in the M mode is the loss of that blue band, but we are seeing the filling into the left MCA adequately. And so that's suggesting that there is collateralization, adequate collateralization happening within the circle of Willis, suggesting that the circle of Willis is complete and allowing flow to shunt from the left to the right hemisphere or posterior to anterior hemisphere as well.
And the reason for that, again, is because you see this is blue, so it's going away from the probe. But on this side, you've lost the blue band, but it's replaced with a red band, so it is coming towards the probe. Is that basically, do I have it right?
Yeah, that's correct.
Okay.
There you go.
Nice job.
Okay. Next slide, please. And it's going to do this again until I'll tell you what. I have. This has been you guys have been great, but this has been a serious challenge for me today. So let me go to the next slide. That's this one.
Yeah.
And from current, there you go.
Yeah, so the next slide is, again, the right carotid clamp is removed, and we see the return of the normal M mode and flow directions within the circle of Willis with the red and the blue M mode presentation. The patient is being warmed up now, so we're seeing a slight increase in the perfusion up to the brain as they're beginning to return normal cardiac function to the patient. And then on the right side is a return to normal cardiac function. The aortic arch has been replaced now with a synthetic graft, and it is showing stable, clear waveforms with good upstroke and no signs of any abnormal flow going up to the brain. The only interesting finding with this is if you compare the return of normal cardiac function slide to the baseline slide that we had before the procedure took place, we see a slight increase in actually the pulsatility. So normal pulsatility is from 0.8 to 1.2. With these on both sides, we're seeing about a 1.5. So a borderline increase, but that was suggestive of the fact that now the aortic arch is a synthetic graft with multiple large artery synthetic graft branches coming off of it. And due to the essentially not having the same resiliency as a normal vessel versus a synthetic graft could potentially increase the pulsatility index, which isn't necessarily an abnormal finding, but something to just note as you move forward and follow up with this patient postoperatively.
Okay. And I don't know why it keeps going back to this video. I'm having a really, sorry about that again. So let me go to the next slide if I can.
Sure.
I'm doing the best I can do. I don't know why.
That's all the videos now, Joe. So the rest are just
Okay.
still shot images. So it should be smooth sailing.
Okay. And, okay, we just have to keep it like this, and we're going to, the slide will be a little smaller, but I still think viewable.
Okay. Josh, are you able to speak to this one?
I think the next couple of examples are a little bit shorter. This is just an example of a common carotid artery graft. So the common carotid artery, I think it was a replacement of the graft, which was compromised or obstructed. And so you can see in that very first image below there on the left side of the screen, you have your left MCA, which represents a normal waveform. In the M mode, where you see kind of a discontinuation of the band itself, those darker spots are what we call a bruit, and those are associated with typically with increased flow, sometimes with stenoses or narrowing. In this case, the left side has elevated flow because it's compensatory to the right side. And you can see on the right side, the waveform is lower and dampened, which means that right carotid graft was obstructed. During this procedure, I believe this was a dual surgical case where they did a CABG and replacement of this graft. And so the patient was on bypass. That's just an example to show what bypass flow looks like, which we did see in the previous cases. And then post-operatively, we see normalization of both sides. And so for all the various reasons we've mentioned prior to this about why you'd want to monitor, in this case particularly, we'd probably be more concerned about emboli because they're dealing with the carotid itself, as well as the flow. But a large shower of emboli and changes in flow would be of concern. In this particular procedure, it went without a hitch. It was, there were no side effects of the procedure itself other than the fact that the artery returned to normal, and we can see that. Mm-hmm. And so just to point out, I mean, if you're not monitoring the blood flow, we really just, I don't want to say assume, because they clean the artery out, clean the artery out or they replace the artery. And so they know that the flow is normal and the artery is normal or the graft is normal. But you can have complications. You can have plaque growth, you can have reobstruction, reocclusion, and you don't find that out unless you're monitoring with Transcranial Doppler, because it's the only real-time method. You would have to get subsequent imaging, again, which isn't routinely performed unless there's an issue.
Right. Let's go to full screen. Everybody, go to take the slides down for a second, and let's just go ahead and discuss this real quick. I think that's a very good point that you're bringing up. Is that, again, we don't know what we don't know, right? That's the primary problem is we don't know what we don't know, and that's always going to be the reality of this. So I think that it has a lot of value, and we should, I think, use it. Of course, carotid surgery isn't necessarily in our bailiwick. I see the value of it, certainly. I think we want to talk about that. But I'm really interested in this, in the use of cardiac surgery, and would like to see, obviously more of that. But, again, in deference to time, I think, Josh, if we could wrap this up, I'd appreciate it very much. I have to, again, I have to be compliant, and we're already 15 minutes, into this. So if we could just maybe go quickly through the rest of these slides, it would be appreciated.
Yeah, definitely. You can. Yeah, again, so this isn't a cardiac case. Sometimes they may use perfusion, but this is during a transcarotid periodic revascularization. Just, again, like the previous cases, there were some issues during the case, which showed reversal of the carotid, which you can see in that first slide. Again, you see the flow changes, and then we can, alert the team, and they adjust things properly. I guess we were on to the next slide here. So just some highlights of some existing literature. Over the last year, there's been quite a few papers that have been published.
Right here in Houston.
Out of Liverpool. We have a nice letter that was published showing their experience, which we just showed with the case.
Well, I can tell you, Dr. Lumsden and Dr. Durrami both are incredibly involved and believers in imaging. We don't do enough imaging, and I see you have the Methodist papers on there. They do incredible work there with this. I know they have that one with the CPR and seeing ineffective CPR with no cerebral blood flow, and then the faculty or the staff physician got involved and started really pumping on the chest, and of course you saw really good cerebral blood flow at that point in time. But very, very, very interesting. And I know I'm assuming they're using it there. How do people? And let's just do this if we can. I hate to cut you short, but I have to. How does our audience reach out? How do we get a hold of people if we want to get an evaluation? What do my audience do, whether they be here in the United States or whether they're here in Houston, in the United States, or anywhere in the world? What do they need to do to find out more about this device?
You know what? They can always contact me, and I'll point them in the right direction.
They don't know how to contact you. None of us know how to contact you.
Say my contact info?
So what we'll do is, David, can we add to the comments in the video Mike's contact information after post-production? We will put it in the description of the YouTube video, so people that see that will get that.
And I'll point them in the right direction.
And they can always go to novasignal.com. Can you, you guys have a website, right?
It is novasignal.com.
It is novasignal.com. See, I got it right. And let me just pull that up if I can. I'm going to go to novasignal.com. Click go. And for the viewing audience, man, I really am glad Nothing popped up on that iPad. Whew. I'll tell you what, I was stressed. I was worried. But there you go. There's our website, and there's a convenient contact us button. They've got some real good information in here. I've looked at the site before. And look, at the end of the day, I think perfusion, just go ahead and take the slides down, thanks. I think perfusion needs to get more involved with this kind of technology.
Right.
Of course, we're not involved in TCAR. We're not involved in carotid surgery, generally speaking. But I think that for our cardiac surgery platforms, I think we need to add this into our tool chest, if you will, in order to provide better quality care. Because the more it's used, the more that's sold, the more it becomes a standard of care, the more affordable it's going to become at the end of the day.
That's right. And you know, we want to make this towards to be the 5th vital sign. That way your cerebral blood flow is just measured every time.
It should be the first vital sign at the end of the day. Like I said, you can cut somebody's kidneys out.
Right.
Okay, and you can take them to somebody else, put them on ice and take them to somebody else. You can take the heart out, you know, with some cardioplegia. You got 4 hours before you have to stick it into somebody else.
Right.
It's very hard to go 4 hours without blood flow to the brain.
You can't do it.
It's very hard to go 4 minutes. You know, 4 minutes is the limit, right?
Yeah.
But at minute 3 and at minute 2 and at minute 1, injury is occurring. It may not be complete brain death, but I can tell you right now, 2 minutes without blood flow at normothermia for any reason is probably not going to result in a great outcome for you neurologically.
Right.
So I think that we really need to pay better attention to what's going on. And when we're doing bypass surgery with so many things that can happen during that time, this just seems like, I'm going to say it, a no-brainer. We should be monitoring blood flow to the brain.
No pun intended, huh?
No pun intended, I think so.
And if anyone is interested, we're always happy to share information. We're always happy to get a demo or eval out.
Absolutely. Okay, Josh and Matthew, Mike with Nova Signal, this has been excellent. We've gone 20 minutes over. I hope everybody doesn't mind. Thank you for your patience and understanding. Information will be in the description on the channel. And anyone has any questions, please email me, and I will forward those emails on to Josh, Matthew, and Mike as asked or as it's appropriate. Thank you all very much. Have a good day.
Thank you, Josh and Matt. Appreciate it. Thank you.
Thank you.
Thanks, everybody.
Thank you.